Mr. Jones. Mr. Jones is here for Mr. Pera's bill.
Item 3.
S.B.981.
Thank you, Mr. Chairman, members. S.B.981 addresses a problem that's confronted this committee and the legislature for a number of years: how to protect consumers who have health insurance coverage from being balance billed by non-contracting providers. In most cases, this occurs when there's a billing dispute after the patient visits an emergency room. And as we all know, in a life-threatening situation, you go to the closest ER you find, even if your health plan doesn't have a contract with all of the physicians there. In these situations, an ER physician may bill the patient directly for the difference or the balance between what is charged and the amount reimbursed by the health plan that covers the patient. This practice of balance billing puts the consumer squarely in the middle of a billing dispute between the treating ER physician and the health plan. And if left unpaid, consumers are at great risk of having their bills referred to a collection agency, potentially jeopardizing their credit history. Under the Federal Emergency Medical Treatment and Active Labor Act, ER physicians are required to provide emergency medical services. They have no choice. And insured individuals expect that their health plan will fairly reimburse the ER physician who provides the care, and oftentimes they go in assuming that they're covered. And they may not know or even think to know that one of the people in that ER room, in fact, isn't in contract with the plan. The bottom line is, though, if there are these disputes over the level of payment, the consumer should not be caught in the middle, and that's what this bill does. SB 981 addresses the issue essentially in two ways. First, it prohibits ER physicians from balance billing health plan enrollees. Second, it establishes a dispute resolution process that takes the patient out of the middle and ensures fair treatment for both the ER physicians who provided the service and for the plans. The key elements of the dispute resolution process are as follows. First, there's an interim rate. Health plans will be required to make an interim payment to the ER physician. The rate would be set at the median of ER physician charges as collected by Medi-Cal. Second, there will be a single billing standard. ER physicians will be required to use the Medicare standard for bill coding and bundling of claims, and this will go a long way in reducing the number of unnecessary disputes and increase system efficiency. And third, the bill provides for an independent dispute resolution process. If billing disputes are still unresolved after exhausting a health plan's internal processes, complaints can be submitted to an independent dispute process established by the Department of Managed Health Care. The existing Gould standard, that's G-O-U-L-D, would be used for determining reasonable and customary reimbursement. Decisions would be based on baseball arbitration, requiring the independent dispute resolution process third-party arbitrator to choose between the physician's initial charge or the plan's initial payment. And then the loser in that dispute would be responsible for paying the cost of the actual process itself to the independent dispute resolution process. In summary, the author knows the question of the interim rate remains the most contentious part of this bill. There were some issues raised about it in the analysis. And you're going to hear that from the witnesses, various stakeholder groups that have been engaged in this process for over a year now in discussing this bill with Senator Perot and his staff. Based on the analysis of the Medi-Cal charges data, the author recognizes that we haven't landed finally on what the right formula should be for the interim payment. It's going to need some additional refinement, and so the author and his staff are interested in continuing to work with the stakeholders in this process so that it better reflects actual revenues now received by emergency physicians. The author believes that this issue can be resolved over the next 10 days and that negotiations also can be completed with the administration. The author requests respectfully that this committee vote aye on the bill to allow the bill to move forward so that these issues can be addressed. With that, we have some witnesses.
Senator Jones, the Romero bill was a result of intensive negotiations that were conducted today, and we reached a compromise. At least we neutralized the opposition. We attempted to do this with this bill, but I just heard you mention the fact that you hope that something can be worked out in the next 10 days. Did I understand you correctly?
Well, I know that there have been some conversations with the chair about various alternative interim payment standards. And I think the author and the author's staff would like the indulgence of the chair and the committee to continue working on precisely what that interim standard would be, recognizing that it does need some additional refinement and that, as you're going to hear in a moment, there still remains disagreement amongst the stakeholders as to what that interim payment standard should be.
Well, we're going to go up to the 3 minutes because this is such a very, very sensitive issue. So you have two lead witnesses at 3 minutes each.
Yeah. Thank you. And I'll allow the witnesses to decide amongst themselves how they want to divide up the time.
Well, if we can get, please cut us off at 6 minutes among us, and we'll try to be as
you know, we'll lose.
Okay.
If you're nice, we'll lose.
Well, we'll try to make it meaningful so you'll want us to continue. I'm Jim Ranlett. I'm the lobbyist for the California chapter of American College of Emergency Physicians. In the overall perspective of this bill, first, it only deals with emergency physicians. Not included are hospitals, anesthesiologists, radiologists. We have stepped forward as our group to try to solve this thorny problem, and we are committed to trying to come up with a solution where the patient doesn't receive a bill even though you don't have a contract with the HMO. The second thing is we support this bill as it provides a framework for doing just that, and we believe that it has the capability of delivering a solution where the patient doesn't get a bill, but ERs don't get hurt. And that is the fundamental message we'd like to bring to you today, is that we would like to see you, both in your policy and eventually the language of this bill, have a bill where you do not, repeat, do not reduce revenues to emergency physicians and harm ERs and, of course, the patients that access them. And we're delighted to work out any system for getting there, as long as the system doesn't produce a reduction in revenues to ERs. And this committee, more than any committee of the legislature, knows the tenuous conditions for emergency departments. And I would hope that you would join us and not vote for a bill that would reduce these precious revenues so that ERs suffer. Our witnesses can get into that more. I would just point out in my closing, say that we've handed out a graph that shows to you, if we've heard, but of course they're not talking to us about it, that the HMOs are promoting a reimbursement level that's 200% of Medicare, which is shown on the graph that's handed out before you. That sounds like a lot, but Medicare has no capacity in its reimbursement system to pay for the 2 million uninsured patients that visit ERs each year, or the 2 million Medi-Cal patients and get tremendously unreimbursed for visiting ERs. So our charges have to be higher, our receipts have to be higher from the insured patients. If you adopted their proposal, as shown on this graph, it would be $70 per visit less than current revenues, which would produce a reduction of revenues to the emergency physicians of $115 million. So we would ask that you not go with that HMO proposal, if that's what they come forward with today, and instead keep in mind that we should have a system where you maintain current revenues. No more, no less, just current revenues. And with that, Dr. Billy Mallon is our president, and he can speak to the emergency system.
Before we begin, members, one issue is not at stake here, balanced billing. Everyone is in agreement that they're opposed to balanced billing. Am I correct about that? Yes.
Yes.
So what we are talking about is the rate cut. Proceed.
Honorable Chairman and members of the committee, my name is Billy Mallon. I'm the president of California ACEP. We represent about 4,000 emergency room docs across the state, of which about 2,600 are members. Emergency medicine as a specialty sort